Hello, and welcome to our our live stream. We're here with Dr. John Awowale, an orthopedic surgeon with Orthopedics and Sports Medicine BayCare Clinic. He's board certified by the American Board of Orthopedic Surgery and is fellowship trained in sports medicine with a special interest in shoulder joint replacement and hip arthroscopy. We thank you so much for joining us today, Doctor. It's always good to have you.
Thanks, Femi. Thanks for having me.
Thank you. This live stream will focus on shoulder labral tears and shoulder-related issues. We'll learn about these conditions and the treatment options that are available to patients. Before we get started, though, we want to invite you, our viewers, to go ahead and ask your shoulder-related questions in the comments section. As a reminder, the information shared today shouldn't take the place of advice of your primary care physician. It's just an informal, informational type of situation where we want to help create awareness as it relates to shoulder conditions and available treatment options. So please keep that in mind. We'll do our best to answer your questions in real time, but if we don't get to your questions during this broadcast, we'll definitely get to them after the broadcast concludes. And if you don't feel like asking questions, you're a little shy or whatever, maybe just give us a like. We'll take that too. That helps us out. So thank you so much in advance. Having gotten rid of all that, Doctor, let's just get right into it. This is probably med school 101 stuff for you, but can you tell our audience what is a labrum and what is its function in the shoulder?
Yeah, absolutely, Femi. That's a good question. To kind of understand the labrum, you just kind of have to have an understanding of what the anatomy looks like. So a labrum, if you want to think of it like an O-ring around your ball and socket joint of your shoulder. So this being the socket, this kind of being the ball, there is this structure called the labrum that kind of works as like a gasket and an O-ring around there. Okay. It's ligaments and tendons that kind of all function together to stabilize the shoulder.
Okay. So how does a patient tear his or her labrum? How does that happen?
So there's a couple different ways you can tear a labrum. The most obvious way that you tear a labrum, as I said, it kind of helps with stability of the shoulder. So The most obvious way would be to dislocate the shoulder. So if you can imagine the ball coming out of the socket, that O-ring is going to be torn as that ball's coming out. Another way that people can kind of tear their labrum is sometimes they can have a fall onto an outstretched arm, sometimes lifting a heavy object. Repetitive overhead sports such as volleyball, baseball, obviously, and racket sports can sometimes tear the labrum just from pulling over and over again on the structures around the joint.
Wow. So what does a patient feel when his or her labrum is torn? Is it a painful thing? Is it something where they don't notice? Like, how does that go?
Yeah, great question. It can happen a couple of different ways. The example I gave before, when someone dislocates their shoulder, obviously they're going to kind of know right away that they've done something and kind of torn that labral complex as they come through with that ball coming out of the socket. Sometimes patients have, like I said, repetitive over and over activities such as throwing, where they can develop a kind of labral tear in a certain part of the labrum. And so it might not be an acute event all at once, but, over time they kind of develop this ache in their shoulder where they start to kind of notice, easily, fatigability, weakness, pain in the shoulder, pain with certain positions of the shoulder. So all those I take into account when I see patients.
Yeah, so that actually feeds right into my next question. So are there symptoms that are described by labrum tear patients? Obviously they don't know what's going on, but they come to you and they say, I'm feeling this, that, the other, and then you immediately just know that sounds like a labral tear.
Well, when I see patients, I kind of use their history as well as physical exam to kind of put all these things together. So I figure out, when did this pain start? What kind of mechanism was it? And then also with my physical exam, I'm able to kind of assess the shoulder. As I keep alluding to, a lot of it has to do with the stability of the shoulder when we think about labral tears. So if you can get a patient to come, kind of be comfortable enough or relax enough, you can actually feel their shoulder kind of shifting in the actual socket, and I can feel that, and I assess the other side when I'm testing that to see if they actually have a little bit of sliding of that humerus inside the socket joint there, meaning potentially they might have a labral tear. There are some patients that just are really flexible, and sometimes that's just how flexible they are. But that's one thing I can test. I can kind of also test if they have pain in certain positions, if they're coming overhead.
Sure.
For other certain injury patterns in terms of the labrum. So there's a couple different things I take into account. And again, as we mentioned too, sometimes patients will have weakness as well.
Right, right. So I understand there are different types of labral tears, at least a couple that I know of. Can you delve into those for us?
Yeah, so I did kind of give the example of the shoulder kind of dislocating. Generally, people dislocate out of the front of their shoulder, usually kind of with the arm in this position. That's more of an anterior kind of inferior labral tear, or just kind of a front labral tear. There's another kind of classification of labral tears called slap tears. And what that stands for is superior labrum anterior to posterior tear. So essentially, if you think about this as a 360 view and you're just kind of looking at the cup right here, the labrum goes all the way around.
Right.
If this is forward, this is kind of where you're going to have that dislocation labral tear. Over the top, or these repetitive throwers, a lot of times they will get labral tears up on the top. And so that's on the superior aspect. You also have another structure kind of inserting there called the biceps tendon. So that all kind of comes into play when we're thinking about treating these labral tears.
Okay, what's this BayCare tear that I've heard of?
Yeah. So if I gotta go back to this, the BayCare tear is really that anterior inferior. If this is going forward, what happens with the ball? That usually people dislocate out this way, and so they usually will have kind of this injury right in this area. So that's the term that people kind of phrase that BayCare tear right in that spot, because he's the one that kind of discovered that injury and the correlation of symptoms with it.
Okay, you touched on this briefly, but give us a good sort of explanation as to how you diagnose a shoulder labral tear.
Yeah, there's a couple of different modalities. So initially, a lot of my patients, I'll like to get X-rays on them just to make sure that they're not experiencing some sort of fracture that I can see on the X-ray or something obvious that we're missing. After we get past kind of the X-ray phase, the X-ray can also show me if they are sublux, meaning they're kind of slid out of the joint a little bit, or sometimes they're overtly dislocated out of the joint. If we've gone past that part, I'll obviously do my physical exam as I described before, but we can also get an MRI and look a little bit closer. The difference between an X-ray and an MRI is an MRI can actually show you soft tissue injury. It shows soft tissue structures around the shoulder, and that can really kind of show me the labrum. Sometimes even labral tears can kind of hide on the MRI, but that's kind of the next step.
Okay, well, thank you, doctor. That's great information so far. If you're just joining us, we're speaking with Dr. John Awowale, an orthopedic surgeon with Orthopedics and Sports Medicine BayCare Clinic. We're learning about shoulder labral tears and related shoulder conditions. Feel free to ask your shoulder-related questions in the comments section, and we'll be happy to answer your questions. Keep in mind, if we don't answer your question during this live stream, we'll definitely get to them at the conclusion of today's broadcast. So let's get back into it. So we have an image of a labral tear coming up, and that means nothing to me. Can you explain what we're seeing here, doctor?
Yeah, it can be confusing to kind of set the scene here. This is a picture of inside a rugby player's shoulder, 24-year-old rugby player that had recurrent dislocation, kind of subluxation events with that BayCare tear that I talked about, where the ball kind of comes out the front of the socket. He developed this from tackling. And he had tried some non-operative management, working with physical therapy, just wasn't getting better. And so what you're looking at here on the left side of the screen, there's actually the humeral head, so that's the ball. And on the right side of the screen, that's the socket. Where that black kind of instrument is coming through the top there, that's from the front of the shoulder, and that's me with my instrument kind of going in between the labrum and the socket, okay? And so that labrum is kind of all that tissue to the left of that black instrument, and I can see that there's actually a hook on the end of that you can't see because it's actually in the other end of the tear. So that essentially is that BayCare tear that we talked about. That should be kind of acting as a bumper, not allowing the ball to kind of slide out the front, but it can in this case because of that tear.
Okay, so, with my untrained eye, it looks like there's a sort of like this frayed line in the center there. Is that the tear we're looking at?
Yeah, that's actually the tear.
Okay.
So that's almost like a cleft. If you were to think of maybe a canyon or whatnot, that cleft
Right.
goes pretty far to the right that you can't see behind the socket.
Okay.
And so, when someone comes out of the shoulder with a dislocation, that you just don't have the restraint there because of that cleft. And so the labrum's just not functioning correctly.
Okay. All right. That is really cool, I have to say. So, can a labral tear just kind of heal on its own over time, or is surgery a must? Are there non-operative options? I'm throwing a lot of questions at you, but
No, those are great questions, Femi. So, depending on the type of labral tear and the kind of type of event, a lot of these can heal, on their own without an operation. And generally speaking, I like to try to get people in physical therapy, working with therapists on strengthening kind of a lot of the muscles around the shoulder, strengthening the rotator cuff muscles, as well as the other muscles kind of around the shoulder blade can really take up for this little bit of an injured structure that's in the shoulder. So it can kind of heal on its own a bit. And so that's generally where I like to start.
Okay. All right. So, and I've talked to some of your colleagues in the past for similar live streams on other health issues. And to a person, they always say surgery is never the first option, but it can be an option for those who need it. So, for example, if you see a situation that doesn't quite rise to the standard of surgery, what do you tell that person in order to get them back to health?
Yeah,
with a labral issue.
Yeah. A lot of times I'll explain kind of the process that's going on, and we'll kind of discuss their goals, moving forward. And a lot of times we can get them in with our physical therapist, or even sometimes I can give people physician guided exercise programs that they can do at home. But a lot of it's trying to regain the range of motion as well as the strength to overcome kind of the labral injury itself. And a lot of people can get back to doing the activities that they were before the labral injury, non-operatively.
Okay. And then when does surgery become the cure?
Yeah, that's good question. And it kind of comes in different forms depending on the patient and depending on the type of injury. There's been a lot of studies that do show now that patients that are, under the age of 20 and are in a high risk dislocation sport, such as football, rugby, that are kind of doing a lot of these high risk sports where they can re-dislocate. Some of them tend to gravitate more towards surgery because they're, in an event that's probably going to lead to that again. A lot of patients, if you just have a spontaneous fall and maybe you have a labral tear from that, a lot of times you can get back to doing your activities in daily living because you're not falling all the time. It was a one-time event, so you're not putting your shoulder in that type of risky situation, if you will.
Sure. Great stuff. So without diving down too deep, can you give us sort of a description of what occurs during labral tear surgery? So, for example, is a patient awake? Are they sedated? How long is a procedure? Like what happens behind the scenes, but don't dive down too deep.
Yeah, no, those are all great questions. So in general, labral surgery is going to be an outpatient procedure. So you come in, you leave the same day. Obviously, you have to have somebody that can drive you there. But you're going to go into the preoperative holding area. I have all my patients get a block before they have this labral surgery. So what that means is the anesthesiologist is able to numb up all the nerves, so the patient's still all the way asleep during the procedure, but when they wake up, they don't have, significant pain in their shoulder. After that occurs, and you head back to the operating room and the anesthesiologist will put you asleep. Once you're asleep, I'm able to actually assess your shoulder when you're completely relaxed. So that actually gives me a little bit more information. When a patient's not actually firing their muscles, I can kind of get an unbiased examination of their shoulder to kind of see how far they're actually sliding out. Sometimes patients get posterior labral tears where they'll actually slide out the back. So it gives me a little bit more information. And then the majority of these surgeries we're doing through an arthroscopic technique, meaning there's small incisions around the shoulder that I'm able to put my arthroscope or my camera, like this image that we're looking at here, through this to really assess the labrum and repair it with anchors. The procedure itself probably takes about an hour and a half. And then patients are, kind of discharged home that same day, immediately afterwards. They don't have much discomfort, as I alluded to, with the nerve block, and then we give them pain medication for the next couple of days.
Okay. And this is definitely a procedure. It sounds like this is done in the operating theater. This is not like come into my office. We'll fix you
Yeah.
up and send you out of here, right?
Yeah, generally we're doing this under general anesthesia with the patient
Right.
fully asleep. So it's going to be in an operative suite,
Right.
either an outpatient surgery facility or potentially a hospital.
Okay. Sounds good. Thank you.
Yeah.
And then what's the recovery time after undergoing this type of surgery,
Yeah.
generally
So
speaking?
no, all like I alluded to before, some of the tears are a bit different, but in general, patients are
Yeah.
usually in a sling after surgery for about 6 weeks. But we're starting physical therapy before that to kind of get some of your range of motion back. Then we come out of the sling, work on some strengthening. People, if you're a high level athlete that's trying to get back to overhead throwing or whatnot, people generally aren't back to throwing at the mound if it's a pitcher for about 5 to 6 months. So in general, that's kind of the timeline of getting back to sport. But people are feeling pretty good at that 3-month mark. They're just not fully released.
Okay, good stuff. Good stuff. So we have another image coming up, and it looks like it's one of a repaired labrum. That'll come up in a sec. And then you can maybe just tell us kind of what we're looking at with that image.
Yeah, so this is the same exact view, same exact patient. And so this is after we've repaired that cleft. So you can kind of see, you can make out some suture material towards the top of the image there. And there's even a little bit of an indentation lower than that where there's another suture anchor there. And there's another third suture anchor that you can't quite make out. But you can kind of see the difference if you remember the other picture. Now we've got a nice bumper in front of that humeral head, which is on the far left of the screen. So the ball has a bumper that it's not going to come out of the socket as readily as it was before. And so what you're seeing there is the final pictures of the labral repair itself. So you can kind of tell the difference between that cleft that was there before and now this nice bumper creating that stability in the shoulder.
Right. That's really neat. So this patient can essentially return to an active lifestyle at some point.
Yeah, he's back playing rugby again. So eventually we try to make sure that the patient's range of motion and strength is stable. That's why every patient's a little bit different in terms of getting them back to sport. But once they're comfortable, usually are able to kind of get them back to those contact sports around 5 months. Sometimes a little bit longer depending on how things are going. But otherwise, yeah, he's back doing everything. He's doing great.
Yeah. So my follow-up question is, a patient like this, would he or she have any restrictions once they receive the all clear from your office?
Generally not. Some people will tell their patients to still brace. So they do make some braces that you can get over the counter and through prescription that can help you as well with instability of the shoulder. But in general, after the procedure and after they're all clear, they are able to get back to all their activities without bracing.
Okay. Well, what are some of the common risk factors for a shoulder labral tear? And you may have mentioned some of these earlier, but just kind of
I can do a recap of them. In general, when I'm seeing a patient, the risk factors that I'm looking for is a younger patient, particularly under the age of 20. Male athletes tend to have more instability or in higher contact sports, which portend to more instability of the shoulder, meaning labral tearing. Overhead athletes that can, have a repetitive overhead sport. Yeah. And, people that are in high risk positions as well. If you're, like I said, contact before, if you're tackling, if you're a football player or a rugby player, you're constantly tackling like this, kind of arm tackling like this is a risk factor. So mechanics, I would say, in sports as well. So good form tackling is definitely going to cut down on your risk of these labral injuries.
Right. And, if I'm not a rugby player or a football player, or if I don't play tennis or badminton or anything like that, what can I do to prevent labral tears?
Really just kind of good mechanics, good lifting mechanics, obviously not trying to do a lot of stuff, away from your body, not getting in awkward positions. Also really not trying to lift objects that are too heavy as well. So it definitely, anybody can get a labral tear. It doesn't need to be an athlete. Right. So you can definitely, take steps to be more ergonomically safe with different, things throughout the day in terms of lifting.
Sure. That sounds good. Well, great. Thank you so much, Doctor. We've covered a lot today in a short period of time. But is there anything else you want to add? Anything that we haven't explored yet that you just want to quickly touch on?
Labral injuries, a lot of them, people that have shoulder dislocations think they need labral surgery immediately. A lot of times that's not the case, but if you continue to have instability events, then sometimes it can lead to that. There are some other procedures as well that we didn't touch on that don't have to do through a scope that you can actually do open with a big incision as well. So some people get into a scenario where they've had multiple dislocations, even after surgery with a scope. So sometimes patients in that scenario go to an open, bigger procedure too.
Okay, great. Well, then some final thoughts from you. Can you remind our viewers what they should do if they feel they have any symptoms similar to anything that we've discussed today, and maybe they've got a labral issue going on? What should they do?
Yeah, if your first hunch is that you've got a labral issue, first of all, I wouldn't stay in a sling. A lot of people want to get in a sling for a long period of time and kind of stay in that. It can help if you have a labral injury, maybe for a week to be in a sling, but much longer than that. People can get a frozen shoulder, which is kind of the opposite direction. So you want to try to avoid that. If you do suspect you have labral injury, you can start to maybe do some range of motion gradually as you become comfortable. And then a lot of it has to do with strengthening, like I said, those small muscles around the shoulder. Right. You can do that with bands. They have resistance bands that you can get at Walgreens, CVS. We can kind of work on small motions of the shoulder, kind of raising in different positions to try to strengthen those muscles. But if that continues, it's not out of the question if you have ongoing shoulder pain to come see a specialist and talk about it.
Okay, and on that note, if somebody wants to come see you, a specialist, is it hard? Is a referral needed?
No, I'm happy to see anybody at any time. All my partners are happy to see anybody at any time as well. So you do not need a specific referral. I'd be happy to see anybody.
Great. And then for those people who think, I don't want to bother a specialist with my achy shoulder or whatever, I should have just taken better care of it. I'll just put some ice on it or whatever. Yeah. What do you say to those folks?
No, I mean, it's one of those things that I tell a lot of my patients not to be a hero. If you're really day to day, you can't do activities of daily living that you used to, whether it be throwing ball with, your grandkids or your son, or, on the field, if you're currently a high functioning athlete, then I don't think it's out of the question to go see somebody and talk about it.
Okay. Great advice. Thank you so much, Doctor.
Yeah, absolutely fine.
And thank you all for joining us. If you have additional questions for Dr. Awowale, please ask them in the comment section, and we will continue to answer them online. Again, Dr. John Awowale is an orthopedic surgeon with Orthopedics and Sports Medicine BayCare Clinic. He is board certified by the American Board of Orthopedics Surgery and is fellowship trained in sports medicine with a special interest in shoulder joint replacement and hip arthroscopy. We thank you so much for watching. Enjoy your day.